I would like to introduce our first presentation, which we're hearing from Diana Paul and Radhika Arasu from Eastern Access Community Health, who are going to be talking to us about their project in caring for consumers with disabilities. Diana commenced at Knox in 2010 and has worked extensively in public dentistry. In addition to her clinical role, she provides student supervision and new graduate mentoring and works in both disability and aged care outreach services. Radhika has worked in public dentistry at Knox since 2008, and beyond her clinical role, she has been active in oral health promotion projects, including outreach work with SRS residents, disability services, and Smiles for Miles. I'd ask you to welcome Diana and Radhika.
Thank you, Louise. Good morning, everyone. My colleague Radhika and I will be presenting on the oral health outreach project, which was aimed at children and adults with disabilities. There were two main reasons why we chose this group of clients. For the first reason, I'll read a quote from Australia's National Oral Health Plan 2004 to 2013, which states that people with special needs experience substantially higher levels of oral disease and have extra barriers to accessing dental care. And therefore, this was the main reason why we targeted this group of clients. The second reason was because it was one of the action plans from the Eastern Metropolitan Region's Integrated Oral Health Plan. So how was it implemented? Our team comprised of 3 dentists, 2 oral health therapists, and 3 dental assistants. A dentist with a dental assistant covered the disability day service, where the clients were of an older age group. The oral health therapist and DA covered the special development schools, where the clients were of a younger age group. And our outreach project extended to the Maroondah and the Knox Local Council area. The places that we visited were Montcalmi, Burke and Beyond, Yarella, Scope, Croydon Special Developmental School, and Irabina Early Intervention Services. The objectives of our project are as follows: to foster a relationship between the oral health team, the clients and staff at the Disability Service Organization, and basically to let them know that we exist and are available to provide care at no cost. Secondly, to ensure clients within the participating disability services have access to preventive dental care. And thirdly, to provide an opportunity to discuss with families the current barriers to accessing community-based dental care. So what was involved in our outreach? We started out by sending out consent forms for oral health assessment to the facilities to be distributed to the parents or carers. In the forms, we requested that the patient's current medical history is included. We found that from the time the funding was approved to the start of the oral health assessment was only about 3 weeks. And the feedback we received from the disability services was that the lead time was too short. Once we obtained the consent form back, we organized for the oral health assessment to be completed at the disability service. The length of our appointments were 20 minutes each. If a client required further treatment, we sent out a second consent form back to the parents or carers with details of our proposed treatment plan to obtain consent to proceed with further treatment. For those who required a referral, we organized it as required. This was the setup at Montcalmi, where Kelly and I went for our outreach. It was our first experience doing this, and we were very impressed with the setup and the equipment. The only drawback probably was that the compressor was loud and the equipments were heavy, which posed an OH&S risk. It was also a very steep learning curve for us. A steep learning curve for us because our patients presented with a range of medical conditions from cerebral palsy, Down syndrome to autism. Some of the challenges we faced were, for instance, clients that had neuromuscular problems that affects functions like swallowing and were at risk of gagging. Some patients with uncontrolled body movement, which made it difficult to complete a comprehensive dental assessment and treatment. Some clients needed to be treated in their wheelchair. The challenge with this was that the cords where the handpieces were connected to were short, and it made it sometimes difficult to move around the patient. So majority of our treatment was provided at the Disabilities Service. Some of the clients were referred to the Special Needs Clinic at the Royal Dental Hospital, and some clients completed their treatment at our local community health services. They were booked in with the same dentist or oral health therapist at each. There were a few who went privately for their treatment, or some declined care. And all clients were placed on a 12-month recall. So this is another picture showing our setup. We were offered rooms that were familiar to the clients. This room was often used for other social activities, and that helped to reduce the client's apprehension. I will now hand over to my colleague Radhika, who will speak about the outcomes of our project.
Results. Out of the 91 participants, 74% received the required treatment during our outreach visits. 20% were referred to the Special Needs Department at the Royal Dental Hospital in Melbourne, and the 6% unaccounted for were either they declined further services, they went privately, so they may have seen a private dentist or a specialist, or they came in to see us at the Community Health Service. Through this project, we increased awareness amongst this group of the services offered through our Community Health Service and other specialist services available. We have also developed a new relationship with the 6 disability services in our catchment and the families, some of which have already started accessing our community health services independently. We have also learnt how we could modify our work practices to increase access to our services, whether it be out when we go out to see the residents. So we tried, or when they come in to see us at the community health services. Specifically, we try, and especially with the kids that I saw, I try and wear the same exact clothing that I wore when I met them, do my hair exactly the same way, and make sure that the nurse that I took with me is doing the same thing. So they are able to recognise who I am, which isn't really hard anyway, but yes. All right, so what worked well for us? Well, as Diana said, we used a room that they were familiar with. So for the adults, it was the activities room, and for the children, we used the arts room. Now, we chose these rooms because it provided a positive environment for them in the first place, because everyone loves doing art. And so they felt comfortable. And with the children, I know with Diana set up, she had the dental chair. With the children, I actually did the checkups in their individual art chairs. So I was often kneeling or squatting or, I don't know, doing funny things just to try and look in their mouth. But the children felt comfortable in their chair. We tried to, we also used these rooms because we wanted to reduce the number of new stimuli, so sensory stimuli such as smell and all the lovely things that happens at the dentist. We kept the operator consistent, so each one of the operators went to the same place, and the dental assistants that came with us was the same as well. Providing care at the disability services was quite advantageous, simply because it didn't disrupt the daily routine of our clients, because often adding a dental checkup to a list of already extensive medical appointments that were required for these clientele was quite overwhelming for the clients as well as the families or carers involved. Where possible, we try to keep the staff and carers present. This was invaluable as they gave us advice on triggers and tips in which to engage with the patients. So with one of my kids, I sounds really bad, but we had a YouTube video of the Rugrats playing because that's what soothed him. Another child found the massage sensory chair quite soothing, so I did the checkup while he was in that chair. I wanted to have a go, but I wasn't allowed to because it was only for kids. Now, what would we do differently next time? Well, initially, like Diana said, we would try and combine the consent form to include the scale and clean or prophylaxis, because simply most of the clientele we saw needed this as well. So instead of having to bring them back twice, we could have just done it in one go. Encourage the parents or the carers to be there, especially with oral hygiene instructions and changing diet and behaviour. It's often hard to make a change unless the parent is there, so because we can make changes at home as well, not only while they're at the school. The other thing, like Dr. Diana said, was the compressor was quite loud and the kids were often frightened when I pressed the pedal on the compressor because it was quite a loud noise. The equipment was quite heavy, so we'd look into modifying this if we ever get a chance to do this again. I pressed the right button this time. So most of the feedback is, I'll let you read this, but most of the feedback we received was positive. But the only time, you can see how, after reading these comments, that there are a lot of barriers that are preventing these clientele from accessing our community health services. So, multiple families reported that they had been to a dentist. They haven't been to a dentist in many years. One of the reasons was often they'd try their family dentist and they had had a negative experience for both the parent and the client. Often they didn't actually know this was quite common, they didn't know what was available out there, to be honest. They weren't sure about the costs of accessing a public health clinic. They were also the parents often were a bit a bit worried about how their child would go at the dentist, and that anxiety that they had was often passed on to the child. And they knew that taking them out of a routine or familiar environment would cause extra anxiety and stress, which they didn't really want to put upon their child. So the disability services, the feedback we received from them was mostly positive. The only thing was that they would prefer a longer lead time into us coming in, just to increase the engagement of more participants. Feedback from us. Personally, I found this outreach project very rewarding. I've done a few, but this would have to be up there. And this also applies to many of the other clinicians that came out and dental assistants. Often we received feedback on the spot, which was very rewarding, especially from the staff and the parents involved. I'll just hand it back to Diana.
Personally, it was a very enriching and humbling experience. I found the adult clients that I saw to be one of the loveliest group of people who never judged you and was there to greet you with a sincere smile. We hope to improve our outreach program this year. We hope to learn more ways to extend our reach to this vulnerable group and to provide the best possible service that we can offer. I would like to say a special thank you to Dr. Maha Gobriel, who provided support prior, during, and after the outreach program. I attended a domiciliary visit with Dr. Gobriel, and she gave me good advice and many useful tips that I've used and am currently using for my outreach program. Thank you, Dr. Gobriel, and thank you all for listening.
Thank you very much, Diana and Radhika. It was really terrific, and I think we could see, it was great to hear about the initiative, but I think we could see the threads or the themes around actually experience matters and the care you took to find a place and space that was familiar for the client, whether it was the adult or the child patient, and actually the partnering and bringing in new relationships with agencies and with others to actually increase the quality of that experience for all the parties. So congratulations. Don't forget that if you want to know more about that, jot down their names and catch them in the break.